sort of constant dialogue between us and the lab people. So this particular study looked at about 2.5 lakh women, which had 886 trisomy 21 pregnancies within that. And you can see for the PAPE at gestations of 8, 9, and 10, the discrimination between the euploids and the trisomy fetuses was much more evident. And this was the case with beta-HCG towards the end of pregnancy, where the trisomy fetuses and the euploid pregnancies, there was much more discrimination here, whereas at 8, 9 weeks, there was a little bit of an overlap between the euploids and the trisomy 21. So the ideal situation would be for us to do a beta, the PAPE at 10 weeks, bring her for a scan at 12 weeks, and then again do a beta-HCG at 13 weeks, and then amalgamate all the results together. So this particular graph on the right is kind of saying that, so if I do a PAPE, say at 8, 9 weeks, and do the beta-HCG at 8, 9 weeks as well, and then the NT at 12 weeks, my detection rate is 87%. But the best detection rate of about 93% over here would be if I do my PAPE at 9 weeks, my beta-HCG at 13 weeks, and the NT at 12 weeks. So you kind of play around, but what the sort of message I want to give you is that the detection rate goes, it changes for when you take the bloods vis-a-vis the ultrasound. So over here, again, in trisomy 21 fetuses, the moms vary from 0.3 to 0.7 between 11 to 13 weeks, and the beta-HCG between 1.7 to 2.2 in all the babies which had trisomy 21. Apart from trisomy 21, bloods helps us to discriminate between the other trisomies, 18 and 13. And as you know, the very, very low levels of PAPE and beta-HCG are seen in trisomy 18 and not so low in 13. So when we are talking about quality assurance, the software has to be important, but also the platform that we use. So the Fetal Medicine Foundation has only validated these platforms. So these are the only ones we accept. So if I'm using FMF software and I have someone come into my clinic with a blood report which say has been done on an Immulite, I will not accept it, because Immulite is not a good platform for doing the reagent. And why is this? Is because the CV has to be really tight. Why is this important? So if I give you an example over here, if the CV, as in this particular case, is about 15%, if I've got a risk of about 1 in 250, which would have come out, if I would have done that test on Immulite, for a 1 in 250, I may have got a variation between 215 to about 1 in 300. So this is too much of a discrepancy when you are giving risks, because you are making a whole lot. I mean, your false negative and your false positive rate is much too high. So you have to have a platform where the variation is so much less, so that at least when you give risks, you're much more tighter. So your false positive rate, or indeed your false negative rate, comes down very low. So we have switched over to Roche, and I asked my lab people to sort of tell us what are the CVs that we use and indeed get, and this is what we do. So we are really quite tight. For me to make sure that the lab is indeed doing what we want, on our software we can we run. I mean, there is an audit where you audit how the blood is performing, and we can see that the standard deviation is sort of acceptable limits, both for beta-HCG and for PAPE. So that is the lab part of things. But what about our part of things? Because the combined test is what we are looking at, it is important that we maintain standards in the nuchal scan as well. This is a nuchal scan which is approved. So if, and I speak to a lot of obstetricians, and I tell them, please just don't look at reports when you get it. Please look at the image of the nuchal scan. Because if the scan has not been done in exactly this way, where the magnification should be high, where I can see a nasal bone, where I'm making sure that I can see the thalamus and the midbrain, that I have got my nuchal translucency well magnified and checked, then that has not been done properly, because it's only on this kind of image, when I measure the nuchal translucency, that it is that it has any kind of validity. So if you have a screen positive, I have someone walking up for a second opinion where they've done a nuchal scan outside, and I look at the lab, and I know that they haven't done it on the platforms that we accept, and I look at the image, and the baby is upside down, the magnification is not okay, I know that the test is useless. And I tell them this, that we do not accept it because it's not been performed properly, and please don't worry. You know, if she is within 13 weeks and 6 days, we redo the whole test again, or otherwise we say that let's, you know, do another form of screening. But it is important that we do that. We have very strict criteria on the CRL as well. The CRL has to be done such that, you know, the image is 60% of the entire image plane, that the baby is lying sagittal, you can see a profile, there's only a little bit of fluid between chin and body, that the baby is not flexed, the baby is not hyperextended, we can see a clear crown and rump, and that is when we say that, okay, that image is okay for us to date the pregnancy and therefore run the blood test. Because unless there is accuracy of the CRL is not there, you will not be giving me correct results, because the whole aspect of biochemistry screening is dependent on an accurate CRL. So unless that's there, your medians are going to be wrong and our results are going to be wrong. So somehow we all have to work together. So you have to work with the sonologists so that the entire detection rate improves. And again, as far as we're concerned, I have to every year have my images audited so that I can get my license. And this is acceptable where it's within a certain range. If these are the kind of graphs we get where the operator is underestimating or overestimating, the license is taken away and they're told to re-audit their performance and redo the whole thing, and then it's issued again. And why do we need the license is because then we give risks. So how did we perform? All of us are FMF accredited. Our in-house biochemistry is on an accredited platform, and we use the FMF software. We do extended screening where we also look at nasal bone, tricuspid, and ductus venosus. This is 6 years data where we did about 4,000 odd first trimesters. These were the ones we excluded. And if we look at the follow-up, and we had more than sort of 90% outcomes, we have a sensitivity of around 92% and with a very high specificity. So it's acceptable. We obviously do everything we can to improve our detection rates further, but at this moment, this is how it is. So as you can see over here, if I have the detection rate of a biochemistry, if you do it at different gestations is different. So if I say have a 5% false positive rate, then it's better at the earlier gestations and even earlier than 11 weeks. Than later gestations. The biochemistry comes down to about 60-odd% if you do it at 13 weeks. And again, this is something that we ask the obstetricians, because I know nothing is in your hand, it's when the test comes to you, but we sit there and make the obstetricians aware that we really need to be ordering these tests much more earlier. So what we have in our hospital is when the woman goes for her booking blood, so when she goes for her routine hemoglobin, etc., we ask her to give her PAPE and beta HCGs. That report comes to me rather than going back to the obstetrician. We ring up the patient and call her for the 12-week scan, and then at that time we amalgamate all the results together and give her the risk. So you may ask that why have we postponed? If I'm saying that everything works better at earlier gestations, why are we postponing doing the ultrasound at 12 weeks? And the reason is that because as technology has improved in biochemistry, it also has an ultrasound imaging. And now our machines are so good that we can pick up problems at 11 to 12 weeks. So I'm playing you a video of a 12-week scan, and you can see, as we are just sweeping down this pregnancy, how much we can pick up. So all this is the stomach, all the sort of omphalocele, the gastroschisis, we can pick up limb defects, we can pick up meningoceles, we can pick up a lot. And therefore, if we can do so much, then we would rather do the test much, much earlier than wait for the anomaly scan or the level 2 scan at 11 to 12 weeks. So it is unacceptable now, because these are detectable anomalies. It is unacceptable for us if a woman has gone past 12 weeks and she's had a scan that we have not picked up anencephalus, the holoprosencephalus, exomphalus, gastroschisis, the megacystis, and body stalk anomalies. I mean, we should have picked it up. And that is a significant number. We again looked at how it works. A couple of centers got together, we from Delhi, Pratima, my colleague from Bangalore. We looked at 12,000 pregnancies and scanned when did we pick up problems. So these were women who went through the center right up to delivery. And it was very clear that more than 50% of all defects were detected in the first trimester. 2/3 of these women ended up having terminations, which is much safer in the first trimester than a mid-trimester abortion. Women die because of second trimester terminations. We have to, it is safer for her to have a first trimester termination. And that's why, again, it was important that we picked up problems. And, you know, it allows for safe termination. The other fallout of this is the fact that in India, because of the PCPNDT Act, we cannot suggest terminations for anything beyond 20 weeks. So at least if you've picked up a problem at 12 weeks, there is enough time for the parents to think about what they want, to meet the pediatric surgeons, to take a second opinion, to think and think again, and be sure on their course of action, because they have 8 weeks in hand to decide how they want to manage this pregnancy. Vis-a-vis doing an anomaly scan at 19 weeks, finding a problem and saying that, look, you have to make a decision in the next 3 days, because otherwise we'll be breaking the law and terminating the pregnancy. So what about cost effectiveness? Again, a study which looked at that, BMJ 2001. So I mean, it's been around for a long time. We in India need to catch up. The integrated test is the most effective, but it is the most expensive strategy. However, whatever test you do, it has to be between these 4. You cannot do anything else. The triple test has to stop. It is not performing optimally. It should not be being used. So this is the extended. So now the other bit, which I'll just sort of briefly tell you in the next few minutes, is when we talk about problems, I spoke to you about aneuploidy, but the other things where we lose babies is because of preterm labor and placental insufficiency, i.e. problems of preeclampsia, eclampsia, fetal growth restriction. This was an NGO which looked at how women die. And it was very clear that if a woman in a developing country, she has 7 times more risk of developing preeclampsia than her counterpart in the West. And if she develops it, she's 14 times more likely to die of eclampsia, even if she's being looked after in a hospital setting. And then taken together, in our country, there is 3 times the higher risk of a woman dying because of these problems than a woman in the West. So we are very now proactive about trying to screen for preeclampsia or for